So Ashley has started the recording, so thank you very much, Ashley, for taking care of that. Good afternoon, everybody. My name is Chris Bruni. I'm the VP of Sales at Security Health Plan, typically joined by my partner in crime, Mr. Jeff Tucker, who is the VP of Business Innovation at the system, but he is not able to attend today. So Karen and I will be flying solo here today and take you through this post-COVID syndrome discussion with Dr. Karen Shulman. So just a few things I want to point out before we get started. Of course, we've got the Q&A and the chat feature in the WebEx, so I'm sure most people are now very familiar with that and know how to use that, but please do feel free to ask us questions during the presentation. We will do our very best to get every one of them addressed today before we end, and if we can't, though, we will get those out to everybody after the fact. So typically within about 24 hours, Ashley will be sending out the recording of the presentation and the PowerPoint to everybody that was pre-registered. So thank you for doing that. And of course, we do post these on the Security Health Plan website. So if you go to our COVID-19 page on our website and then click the employer tab within that page, you'll see all of the different webinars and past ones as well. They're populated for your use and reuse. So please feel free to take them and share them and take them everywhere you want to go. So without further ado, I'm going to go ahead and introduce Dr. Karen Shulman today. Karen is the head of our primary care division at Marshfield Clinic. She is a practicing family medicine doc. Originally grew up in Ontario or in that area anyway, and did all of your medical training in the Ontario area as well. So we're very pleased to have you here. She's board certified in family med. Took care of that way back when in 1996. According to your profile, you've been with the system now for almost 23 years. So
correct.
That's fantastic. So we're very pleased to have you here with us today. You're still a practicing physician and has some rave reviews on the Marshfield Clinic website from patients from this year and from past years. So please feel free to check those out on your own. But I'm going to turn it over to you, Karen, for a post-COVID syndrome discussion. And again, looking forward to this, and take it away.
Thank you so much. Very kind introduction. And I'm going to beg everybody's forbearance. This is the first time I've actually done any sort of presentation like this. So hopefully we've had most of the kinks worked out. The other disclaimer, aside from the fact that I have no association with any other industry that from which I am benefiting from doing this presentation, I just need everybody to know that this is information that's continually in flux. You know, we've got about 13 months of experience with COVID now, and that is just teeny tiny baby steps in understanding most medical situations. So every week we're discovering new information that helps inform some of our guidance when it comes to COVID, post-COVID, and everything like that. But post-COVID, long-haul COVID, whatever we wish to call it, is definitely a thing. We're seeing patients coming in with persistent symptoms after their acute phase of the infection. And so we, as a group of physicians with the Marshfield Clinic, did try to come together and think about long COVID, what we're going to do with it if it becomes, you know, a very busy part of our practice. So part of that was doing a lot of research, gathering some data, some information, which I've pulled together a lot of that here. And I'm trying to keep in mind my audience as being not very medically based, but, you know, with respect to what you might need to know about people who are suffering from post-COVID syndrome. So this, it looks like the scope of the problem is that in people who are hospitalized with COVID, up to 30% of them are going to have some persistence of symptoms in one way or another, which leads us also to about 10% of all cases diagnosed. So since we've had over 30 million cases in the United States, this data was probably from February. So we're looking at several million people managing their persistent illness after COVID. Back in time when we were dealing with the other coronaviruses that made the jump to wreak havoc in the human population, SARS and MERS, would affect, 30% of healthcare workers had persistent symptoms after infection. 16% overall, including 7% of non-healthcare workers. We're still not back to work at a year. So in the United States, that equaled to, 870,000 people. This is not a minor issue, having post-viral syndromes. So the Mayo Clinic, always a leader, had started to pull together their long COVID approach. And so I attended a webinar from them, and I actually agree with and like a lot of their diagnostic parameters, how they're describing it. They prefer the term long COVID syndrome. And the way it's diagnosed is that the patient has to have had a positive PCR test for COVID, and the PCR is the most specific and sensitive test. That's the one that goes back to the back of your nose and pokes your brain. Basically, it's when you have persistent symptoms 4 weeks past your positive test or whenever your symptoms started, that the symptoms are consistent with those of post-COVID syndrome, which I'll review soon. And understanding that although the reasons for this syndrome are unclear, there are a lot of similarities between this and other post-viral syndromes that we see from other infections. So common symptoms, one or several, they overlap in some cases. Fatigue, and the one to the right of that is activity intolerance, post-exertional malaise. So the fatigue is not your general, oh, I feel really tired because I didn't get enough sleep. This is profound fatigue where normal activities of daily living set you back and you just can't do that same level of activity the next day. So that's the profound activity intolerance. Shortness of breath and persistent cough, pretty common after any lung infection. COVID is no different. Clinical depression, anxiety, and PTSD are seen as probably a much bigger part of post-COVID syndrome than other viral syndromes. Definitely, if you had any of these issues prior to an illness, that will increase your risk of having them worsened after. And because of the isolation and the approach to hospitalization and basically withdrawal from society around patients who have COVID, these symptoms are at high risk of becoming quite significant and challenging. Dysautonomia is a fancy word for the nervous system part of your body that is not under your direct control, such as blood pressure management, heart rate management, just isn't firing on all cylinders. So dysautonomia symptoms will lead to unable to maintain your blood pressure when you stand up. So you become very lightheaded very easily. Heart rate sort of going rapid for no reason, not associated with activity, things like that. And brain fog is something that we hear from a lot of patients. It can be seen maybe as a fallout of all these other symptoms, but there also may be some direct effect on the brain during COVID, similar to a post-concussion syndrome, where you just don't quite feel sharp, can't concentrate, can't focus for any length of time. So when patients are presenting with these issues, the initial approach very much is based in a primary care approach. We are trying to get these patients in to do a thorough history, physical exam. Probably 80% of any diagnosis we make is made on the history. You want to pay attention to what was going on before they got sick, what has happened since they've been sick, what their illness was like, how they were treated, were they hospitalized, etc. The other thing to look for are the red flag symptoms of this syndrome. There are some significant inflammatory processes that can affect the heart, particularly in younger people. And sometimes, and people are very much at risk of things like blood clots. Different than the Janssen vaccine blood clot. This is just a general increased risk of venous thrombosis, leg blood clots, lung blood clots, etc. And that's not uncommon with a lot of inflammatory conditions. So after you've done that, there are some basic labs that you can do to rule out other common problems that have similar symptoms, like thyroid dysfunction, anemia. This isn't always related to COVID. There can be other non-related issues at play. Always screening for anxiety and depression symptoms, so you can be aware of that situation. Not everybody will bring them to us. Sometimes we have to be very directed to pull that out. Again, it's ruling out other reasons for the shortness of breath. That's something that other things will cause, like blood clots, like coronary artery disease. So we don't want to attribute things to COVID without ruling out the most important things that you don't want to miss. Respiratory symptoms, the shortness of breath is pretty persistent. Sometimes just checking somebody's oxygen level and reassuring them that their oxygen level is fine. That's the home pulse oximetry. You can buy, lots of people I'm sure bought little finger oximeters on Amazon, so you can check your oxygen at home. We did this a fair amount with people who actively had COVID as well, sort of as a guidance as to when to seek care. Getting a chest x-ray. Spirometry is the breathing test that you do to try to check for asthma, COPD, other underlying problems that can be causing the shortness of breath. And then finally, the cardiac symptoms, when you're feeling short of breath with exertion, feeling any chest pain or chest tightness, significant exercise intolerance in young people who were otherwise previously very healthy. Then we do other testing for the heart, including EKGs and some blood tests to check the heart enzyme levels, just as we would for a heart attack, but they also go up anytime the heart is inflamed. So post-acute monitoring, we call the acute phase of COVID from the time of symptoms or diagnosis through the next 14 days. After that, for the next month or so, that's the post-acute phase. This time of life has been shown to be fairly risky for some other new events, such as blood clot events, clots in the legs, clots in the lungs. Up to 60% have evidence of myocarditis, which is a heart inflammation at 2 months, although in the vast majority, this is asymptomatic. They found this when they were doing MRIs, and you can see evidence of inflammation in the heart. However, it's a not uncommon presentation for teenagers and people in their early 20s to come in with that shortness of breath due to this heart inflammation. Even after admission for COVID-19, after people are sent home, within the first 2 months, about 10% of them died after discharge and 15% were readmitted. Now, there aren't any, I don't have specific details as to what they died from, post-COVID complications or an alternate diagnosis in general, but it's just, you're not right in the clear after you get out all the time. So everybody has to be aware of this risky period, watch for sinister events and the symptoms thereof. And if we are dealing with younger people, we do recommend that people get some blood testing done, look for that heart inflammation, and if so, they get referred off to cardiology for some guidance regarding activity modification so they can avoid risking adverse effects like arrhythmias, irregular heartbeats that can be dangerous. Psychosocial considerations are a huge part of primary care to begin with, and in the COVID patients who are already suffering months of possible isolation, unable to contact or be with family and friends, depression, anxiety, and PTSD are coming up in patients who never had it before, and certainly those who had these difficulties before COVID, it doesn't help it at all. People feel guilty. They wonder what's wrong with them. Why are they not getting over it like everybody else did? The full gamut of COVID has been from asymptomatic infection all the way up to ICU admission and death. We have not identified clearly what the difference is between how it affects each person. In post-viral syndromes, often they can hear misleading or inaccurate guidance, such as suck it up or get over it. And you just can't. These are not helpful approaches to somebody who is suffering with these symptoms after the infection. 13% for professional psychological support is what they were seeing at Mayo. I think 100% of people are going to need some psychological support. They need understanding, they need to be heard. Accommodations need to be made for their expectations in life. It's important that we work with them, understand what their needs are, but we're very reluctant to add too much to making this a medicalized problem. I don't want to start a lot of extra medications or make it seem like it's the end of the world. The majority of these are going to improve. It just takes longer than some other situations. Rehabilitation is really key, and this was the focus of the second phase of dealing with people who have long COVID syndrome symptoms. The physical part, the fatigue, the exercise intolerance is mostly addressed by, ideally by a team of physical therapists and rehab specialists who can guide sort of a graduated response to, it's like a work hardening, but I like to think of it as life hardening. You have to see what they're capable of and not push them too quickly. So particularly for this post-exertional fatigue, it comes from this profound deconditioning, could be associated with the low oxygen from lung symptoms, etc. But if you try to get them back to activity too quickly, flare-ups are common that can put them back another week or two. So aggressively grading the exercise can have a negative effect. So the best effect is to combine it with some psychological support in the form of cognitive behavioral therapy, which is a fancy way of saying explaining what the person has and helping them understand the reasoning behind it and what needs to happen to help them heal. And then the paced activity is being addressed by very small increases in activity every day. Say they can tolerate 5 minutes of walking for a day or two, and then you push it to 7 minutes of walking on a flat surface. Just trying to avoid the flare-up effect of pushing them too hard. Pulmonary or lung symptoms, pulmonary rehab is something we use for a lot of people with COPD or emphysema. And in the post-COVID patients, it's been shown to be very beneficial to help them with that cough, shortness of breath, and then subsequently the fatigue issues as well. Sometimes we're running into, just with everything COVID, because it's all so brand new, insurance issues can be a problem. We're trying to get people are catching up with what diagnoses will be covered for this pulmonary rehab. Medicare is currently capping the number of sessions that are allowed. But again, this is, I'm sure, something that will be in flux and in progress over the next year. So this positional dizziness, the dysautonomia, where position changes or standing up or even going from lying to sitting causes you to feel very lightheaded, sort of like you're going to pass out. Your heart can race, feel very fatigued, makes you want to lie down. So this is a transient irregularity in your body's autonomic nervous system. So 20 to 40% of patients, this can be triggered by any viral infection and may account for why you feel so lousy after you've had flu or a really bad cold. With COVID, they are seeing it to quite a significant degree. And just like anybody else who has this syndrome, you can start with lifestyle changes, making sure they drink enough fluid, including a little bit of salt, but not too much, to keep your tank full. Wear support stockings to help prevent blood from pooling in your legs when you are on your feet. And if it's severe, referrals to cardiology can occur, or we can just add medications that can maintain your blood pressure while your body heals. The brain rehabilitation, I think, is also another work in progress. Brain fog is possibly one of the bigger concerns. And this, I think, can impact people's enthusiasm about going back to work where they may not even have a very physical job, but if they require a lot of focus, a lot of intense concentration, prolonged mental functioning, and they have to be sharp, they may not feel able to perform their job duties. when it's persistent and significant. Even doing a little bit of neuromuscular retraining, basically reconnecting your brain with your body is what this does. Different types of posture exercises, stability exercises, along with the paced activity, and just general good health guidance, good sleep hygiene. Maybe, sort of looking at it like a post-concussion approach. Minimize your electronics, make sure you're getting enough sleep, manage headaches according to the type of headaches that they may be, and then we can get them back on track. If after all our best efforts, or if we find red flag symptoms or signs that somebody is suffering from more than just the general run-of-the-mill post-viral syndrome, we will occasionally need to pull in our specialty providers for additional help. Cardiology and pulmonology, top of the list. Psychology, I think, will also always be considered one of our primary assistance in helping these patients. Physical medicine and rehab is really quite key for getting that strengthening and activity hardening going for somebody. So anything that comes up with an abnormal lab finding, imaging findings from chest X-rays, CTs, we will make the appropriate recommendations. And there are ongoing talks amongst the providers at the Marshfield Clinic about identifying certain providers maybe who have a keen interest in helping people with post-COVID syndrome, long COVID syndrome. And that is ongoing work that we're doing with a committee within the system right now. Occupational health will also be readily accessed and hopefully early, because if there are return to work efforts, they really are the experts at helping guide us as to how to grade return to work appropriately, getting people back in not too soon, but getting people back to normal life as soon as they can manage. The big take home is really infectious disease. Once the infection part is over in the first 2 weeks, there's not a lot of role for them at this point. A lot of patients feel that getting back into an infectious disease specialist would be helpful, but there is no infection. This is all sequelae and side effects and fallout from the insults that our bodies suffer when we are hit with a significant infection. So please refer to the other specialties above. So the outcomes that they were seeing, there are several post-COVID syndrome clinics. The ones we sort of reviewed were Cleveland Clinic, Mayo Clinic. They all tend to be based in a primary care approach first to do the initial testing, evaluation, and physical, and then referrals to specialties are made as needed and as appropriate. So by 4 months, the experience at Mayo is that they're seeing 20% of people having full recovery. And of course, every month we're going to see more and more data. There were only so many patients starting to be enrolled, and we can probably give updates as needed down the road. Certainly new programs would be helpful, but the barriers to developing a new program are sometimes insurance coverage, sometimes issues related to disability, how to get that approved or not approved. I was just hearing on NPR some discussion about Social Security disability with long COVID being a significant challenge, being a new diagnosis, not fully fleshed out about what it entails, what the diagnostic considerations are, how to be certain this is the problem, et cetera, et cetera. So as with all things COVID, we're looking forward to continued research into the pathophysiology, basically the underlying causes, what's happening at the cellular and at the organ levels from COVID that cause these symptoms to be so persistent. How can we best diagnose COVID-related issues related to the post-COVID syndrome versus other non-related medical conditions? Efforts at trying to develop new vaccines in a fairly effective and efficient manner, of course, are ongoing because of new variants that we are afraid might be breaking out. And then, of course, treatments. looking at the methods for the treatments, what the outcomes are, so we can start guiding our therapies more effectively for better outcomes in the most efficient way. And that is the end of my discussion. I'm sorry it took so long. I lose track of time when I'm talking.
No, you did really well. Thank you very much. We do have a couple of questions that have come in. So I'm going to go ahead and ask them.
You kind of, I'm hearing you coming in and out. Sorry.
Oh, I get a little closer to the screen then. Sorry about that. So the first question was, what about people that are suffering with this condition, this syndrome? If they haven't been vaccinated, should they get vaccinated?
Yes. Short answer to that across the board has been yes. We recommend vaccination for everybody. It's not thought that the vaccine, although the side effects that some people get from the vaccine are very similar to these, I have not seen, heard, or read any concern that it's aggravating or prolonging the syndrome.
Okay, and then there's a question that just comes in about what about the lost taste and smell, or that sensation of taste and smell? Is that one of these that lingers on through? I'm paraphrasing what the question might be asking. Is that something that lingers on through post-COVID the syndrome as well?
Yes, it's funny that because, and it may not have been brought in, it certainly is part and parcel of the post-COVID syndrome. Oftentimes, though, and I think it affects the younger population a little bit more, that loss of taste and smell when it happens can be persistent. And I've had a few reports of it lasting for months. One of our internists was asking me about this morning, and he had been reading, there's some therapy that's being recommended, basically retraining for smell and taste. Taste and smell stimulation therapy can help it. It's unclear whether this is damage to the organs themselves, the sensory part of your nose and your tongue that is the problem, or if it's the processing part in your brain that was affected by COVID. So just like any neurologic insult to the body, it can take weeks to months for those nerves to sort of recover and recuperate. We don't have any aggressive, good way of making that better faster right now.
And then what about people that may have had a less severe case of COVID? Are they still susceptible to the same post-COVID syndrome, or have we seen that actually is a lesser recurrence or occurrence of this syndrome?
The less severe the symptoms were, certainly the less severe any of the post-COVID syndrome would be. You know, you may have one or two of those symptoms for a few weeks after the infection. It doesn't preclude you from having long COVID syndrome or post-COVID syndrome. Certainly, the sicker you are and the longer anybody spent in hospital, we tend to see a higher risk of this being a more complex and prolonged problem.
Okay. And then a couple different points that you'd made in the presentation related to PTSD. Why is that more of a as you kind of referenced to the guilt over why did I get it, why did I not get it, why did I survive versus somebody else, or is it something deeper?
I think part of that, but PTSD itself, if there were no problems beforehand, what we're seeing is mostly in the people who are hospitalized or became very, very ill, where they really felt that anytime you're feeling short of breath, air hunger, out of control. But the COVID is complicated again by the fact that they were not allowed the emotional support that most people benefit from during severe illness. They couldn't see their family. They couldn't hold hands with anybody. You know, there was this sense of isolation on top of the physical insult. So it's psychological heaped on physical, all generating very adverse psychological response in many people that probably leaves a mark and will benefit from ongoing therapy and support to help them, you know, integrate that into their experience.
Mm-hmm. Okay. And then another question that just came in, is the elderly population more susceptible to post-COVID syndrome as well, or is it not showing that?
You know, we did not see that as part of the makeup of the people who have post-COVID syndrome. It has spread the gamut. Like I said, the younger people tend to have more of the more concerning problems with the heart inflammation. I don't think it has a favorite gender or age group. Everybody's at the same risk.
Okay. All right, and then there was one question that came in, I guess, to Ashley privately about what is Security Health Plan doing about the insurance issues. Well, we are actually covering a lot of the claims that are all claims related to this. This is an illness that's covered. But the government does step in and has been doing that throughout the pandemic about changing how things are covered or having things covered at a higher rate or a higher level than may typically be covered by their plan. So we honor those and are working with our state and federal governments on all of those types of things to make sure that the insurance coverage is what it needs to be for meeting those mandates. Otherwise, we are monitoring activity at the group level. If you have questions, if you're an employer and have questions about your own group and what we're seeing from a claims perspective related to COVID activities, we have a new report that we're generating, and you can reach out to your account manager and they can help you kind of sort through that. Right now, it's only tracking what we are seeing at Marshfield Clinic, but hopefully that's something that we'll see expanded, because again, we're very early in this. We're just trying to get at some of those underlying root cause analysis and getting at a high level of data right now. But hopefully that's something that we'll continue to see expand. So appreciate all the questions. Karen, I'm going to wrap this up. Thank you very, very much. This was very, very informative. Really appreciate you being with us today. And I hope everybody found great value in this, and we look forward to having you back on again, hopefully on a different topic, or maybe with just a reprise of this one as we learn more. So Karen, thanks again, and have a great day, everybody. Be well.
Thanks for having me, and thanks for attending.
You bet.